Good afternoon. Thank you all for making the time to join us today. My name is Marissa Becker, and I'm an associate professor at the University of Manitoba and CAHR board member. On behalf of Dr. Alexandra King, my co-chair for the Clinical Sciences track for the CAHR conference, I have the great pleasure of introducing Dr. Khalil Ghanem. Dr. Ghanem is a professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine and in the Division of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. He's a very accomplished researcher and renowned clinician and is now president-elect of the American Sexually Transmitted Diseases Association. Dr. Ghanem has been the principal investigator of the CDC-funded Johns Hopkins STD/HIV Prevention Training Center since 2014. His research focuses on reproductive tract infections, in particular syphilis, and the vaginal microbiome. And his talk today is on the intersection of sexually transmitted infections and HIV in 2021. Please join me in welcoming Dr. Ghanem for what I know will be an excellent and engaging presentation.
Thank you so much. I'm very delighted to be with you today. I'd like to thank the organizers for the invitation. I just wish we were all together in the same room. I miss the energy of a crowd. The COVID-19 pandemic has stolen so much from us, but I'm hoping that it will be an impetus for us to make positive changes in the world going forward. The title of my talk is The Intersection of Sexually Transmitted Infections and HIV in 2021. Given the changes that have taken place in both fields over the past 5 years, I think it's an apt time to reassess this long-standing relationship. I have no disclosures related to this presentation. So over the next 40 minutes or so, I'd like us to think about the implications of rising rates of STIs throughout the world and the resulting challenges in prevention and management of these infections. I would also like for us to consider what this means in the context of the significant changes that are happening in the HIV field, particularly as they relate to prevention and treatment. My goal is not to be provocative merely for the sake of provocation. What I'd like to do is force us to think together about how we can synchronize efforts to enhance the control of all of these infections. I don't want to convey pessimism, but I do want to convey my deep concern at the complex and challenging reality of controlling all of these infections. So let me set the stage for this talk. Since the dawn of the HIV era, it was understood that HIV prevention was STI prevention, and STI prevention was HIV prevention. In recent years, highly efficacious biomedical prevention interventions became available for the implementation in patients living with HIV and those at risk for HIV, U equals U and PrEP. These interventions were sorely needed, and they are absolutely phenomenal. The whole landscape of HIV prevention changed dramatically and continues to change with, for example, advances in PrEP delivery options. But then something happened. It wasn't spoken out loud, but for any keen observer, it was obvious. A chasm had appeared between HIV prevention and STI prevention. For the first time, HIV prevention was not necessarily STI prevention. Indeed, there was a flurry of papers which compounded the anxiety, and these papers suggested that while PrEP helped prevent HIV, it may be problematic for STIs. The anxiety in the STI world was heightened even more when the response by some to these concerns was essentially a shrug. That response was perfectly understandable. What are we going to do? Not promote U equals U? Not use PrEP in our patients? But despite understanding the importance of these HIV prevention interventions, the STI prevention field felt that they were at risk of losing a critically important ally. Let's be honest, HIV prevention had become the backbone of STI prevention in the preceding 3 decades. So you understand why many of us felt uneasy, even worried. So that's the stage that I'm going to set for this talk. And I'm going to ask first the question, where are we in 2021 with respect to STIs? And here's my first disclaimer. I'm going to present Canadian epidemiological data in this section because I think they're more relevant to your practice. And because the US data reflect identical trends. It's incredible how closely related they are. So let's start with these data. These are the 2018 data for chlamydia, gonorrhea, and early syphilis for Canada. It's remarkable how well they overlap with the rates of the United States. We see identical trends. For chlamydia, there was a 40% increase in the rates between 2009 and 2018. For gonorrhea, 190% increase. And for syphilis, 259% increase. A 259% increase between 2009 and 2018 for syphilis. Unbelievable. Same findings in the United States, exactly. And so let's focus on syphilis right now, and then we'll focus on gonorrhea next, just to highlight some important concepts as it relates to these sexually transmitted infections. So let's look at syphilis in Canada. And you can see that after a decline, a steady decline throughout the 80s and 90s, and in fact, just like the United States, Canada reached its nadir of syphilis cases around 1999. And then suddenly the rates started increasing in 2000. And since 2000, they have not stopped increasing, whether you're in Canada or in the United States or around the world. And I'll show you some data later on. The rates have not stopped increasing since 1999. It's fascinating. In 1999, the CDC in the United States, the Centers for Disease Control and Prevention, came up with a plan to eliminate syphilis by 2010. And they launched that plan. And within months of launching that plan, the rates started going up, and they have not stopped going up. In 2013, the CDC shut down the plan to eliminate syphilis without any fanfare. So the rates have been going up steadily since 1999. Now, not only are the rates increasing, but the disparities are also quite striking. The same disparities that we observe in the northern territories of Canada are also evident in the southeastern part of the United States. So rate going up and disparities becoming even more evident. Then we look at syphilis in Canada by sex. Again, similar story than in the United States. The rates began increasing in 1999, and they were fairly limited to men, in particular men who have sex with men, and many of whom were HIV infected. But ultimately, women started catching up, and the rates started to increase in women in Canada around 2014, in the United States perhaps a little bit earlier. And the rates have continued to increase in women as well as in men. In the United States, the heterosexual epidemic that's occurring is closely linked to drug use, all kinds of drugs. And of course, when the rates in women start going up, then of course the rates of congenital syphilis start going up. And these are data both from Canada and from the United States in 2018, and they're sobering. Every case of congenital syphilis is a failure of public health. Congenital syphilis can be prevented with the treatment of the mother. And every single one of these cases is a failure of public health. And look what's happening to the rates of congenital syphilis, both in the United States and in Canada. In the United States, in the state that has the highest rates of congenital syphilis in the South, that rate approaches some of the rates of congenital syphilis in West Africa, in some countries in West Africa. It's shocking. It's sobering. You don't blame countries that don't have easy access to testing and treatment, but the United States, that should not be happening in 2021, and it is. And like I said, this is not just happening in the United States and Canada, but it's happening all around the world where they're doing frequent testing, where the epidemiology is followed. Look at Australia, look at the European Union. It's happening everywhere. It's happening in China. And to my knowledge, not a single country has been able to significantly impact the increasing rates of syphilis since the early 2000s. And so this is a problem that the world is facing. And so that's the state of syphilis in 2021. Increasing rates in both men and women, rising rates of congenital syphilis, each case representing a failure of an overburdened and under-resourced public health system, and then stark inequities reflecting, among other factors, poverty, stigma, and structural racism. Of note, I didn't mention, but as a consequence of these increasing rates of syphilis, we're starting to see a lot more complications of syphilis that we had never seen before or had not seen frequently. I can't tell you the number of cases of ocular syphilis, otic syphilis, neurosyphilis, syphilitic hepatitis that I'm seeing on a weekly basis here in Baltimore. So these are the consequences of rising rates of syphilis in 2021. So now let's look at gonorrhea. And I'm going to show you some US data, mainly because the US has made significant changes in their approach to gonorrhea over the last couple of months. And so let's look at gonorrhea. And in the United States, a 63% increase since 2014 and over 140% increase since 2009. So very similar trends as Canada. And so what we've seen with gonorrhea is that there has been increasing rates of antimicrobial resistance. Remember, the United States and Canada, in the United States up to December of this past year of 2020, the recommended treatment regimen was ceftriaxone 250 milligrams and azithromycin 1 gram. But unfortunately, while the MICs to the cephalosporins have been fairly stable, luckily, the MICs to azithromycin and the macrolides have been steadily increasing in the United States. And you can see in 2018, at the time of this recording, these are the last data that we have. Essentially, what you see is that we're reaching the 5% prevalence mark. And usually what happens at the 5% prevalence mark is the CDC says we're not going to use macrolides anymore as first-line therapy. And so up until 2020, December 2020, the United States was using ceftriaxone 250 milligrams IM and 1 gram of azithromycin to treat gonorrhea. But that changed in December of 2020, and we'll talk about that in just a bit. But that's not surprising when you look at what happens with gonorrhea. Gonorrhea, Neisseria gonorrhea, is a naturally competent organism. And within weeks after the introduction of a certain antibiotic, we start seeing increases in antimicrobial resistance. And within years after the introduction of an antibiotic, when it's used almost exclusively, widespread resistance has emerged. This has happened with tetracyclines, this has happened with penicillin, this has happened with the fluoroquinolones, and it's happened with the macrolides. And as a result, again, in December of 2020, the CDC issued an update to its 2015 recommendations on how to adequately treat Neisseria gonorrhea. So we went from ceftriaxone 250 plus 1 gram of azithromycin, and this is where we are now in the United States. When you look at urogenital and rectal gonorrhea, the recommended regimen is ceftriaxone 500 milligrams intramuscularly as a single dose. 500 milligrams as a single dose. Azithromycin has been abandoned because of increasing rates of resistance. Alternative regimens, there are two. One is gentamicin, 240 milligrams IM plus 2 grams of azithromycin. And the reason why it's an alternative is because it was actually studied in a randomized controlled trial and found to be highly efficacious. And then the other alternative regimen is cefixime, but that's changed since the prior recommendations. In the past, it was 400 milligrams of cefixime, but now it's 800 milligrams of cefixime as a single dose. Those are the options to treat uncomplicated urogenital and rectal Neisseria gonorrhea. Now, why did the CDC change the dual treatment regimen recommendation, and why did they increase the dose of ceftriaxone? That's easy. They essentially got rid of the macrolide because of increasing macrolide resistance and for the sake of antimicrobial stewardship. Fewer antibiotics hopefully will lead to less emergence of resistance, both in gonorrhea, but also in other pathogens, with other pathogens. It never made sense to me why they used both of these drugs in the first place. There are no data to suggest that by using two of these drugs, you're protecting ceftriaxone from MIC increases. There are no data suggesting that. And so it was unclear why that recommendation was made in the first place. Now it's been abandoned. Now, why did they increase the dose of ceftriaxone? They increased the dose of ceftriaxone to optimize its dosing. A murine model suggests that the optimal dosing of ceftriaxone is 5 milligrams per kilogram of body weight. And if you translate that to humans, that is a 500 milligram equivalent dose in most individuals who have a BMI that is less than 30. And so that is the reason why they got rid of the macrolides and they increased the dose of ceftriaxone to 500 milligrams. But it gets more complicated than that. What about pharyngeal Neisseria gonorrhoeae? Well, it gets complicated because the only regimen that's recommended currently by the Centers for Disease Control is essentially ceftriaxone 500 milligrams as a single dose. There are no reliable alternative treatments for pharyngeal gonorrhea. So the only option you have is ceftriaxone. And so it behooves you in the United States, it behooves you not to accept willingly that a patient is unable to tolerate ceftriaxone. We're going now to great lengths in order to determine that a patient is truly allergic to ceftriaxone, particularly if they have pharyngeal gonorrhea, because you don't have any alternate options. Not only do you not have alternate options, but any patient that's treated for pharyngeal gonorrhea now has to have a test of cure within 7 to 14 days after treatment with ceftriaxone. So you have to do a test of cure to essentially document that the treatment has been successful at eradicating the pharyngeal infection. And of course, all patients, all index patients with gonorrhea should be rescreened at 3 months because the rates of reinfection are very high. So you can see now that pharyngeal gonorrhea has gotten to be much more complicated in terms of management. So why does the CDC only recommend ceftriaxone for pharyngeal Neisseria gonorrhea infections? And why recommend the test of cure for all pharyngeal infections? Well, even ceftriaxone, the concentrations of ceftriaxone tend to be more variable in the pharynx. And the treatment of Neisseria gonorrhea in the pharynx likely requires longer times above the strain's MIC. And because of that, there's uncertainty about the efficacy, the consistent efficacy of ceftriaxone, even 500 milligrams of ceftriaxone at the pharynx. When you look at cefixime, which is an alternate regimen used to treat gonorrhea, even the 800 milligram dose is insufficient to achieve consistent levels at the pharynx to eradicate gonorrhea. You come close if you were to use 800 milligrams every 8 hours for 3 doses. So for cefixime, you have to use 3 doses every 8 hours to achieve the concentrations necessary to eradicate pharyngeal gonorrhea. And that's precisely why the CDC said, don't use it. And of course, the gentamicin-based regimens are also hugely problematic because while gentamicin is effective for anogenital gonorrhea, it does not effectively eradicate pharyngeal Neisseria gonorrhea infections. So you're stuck. There's nothing really that you can use that's highly effective to treat pharyngeal gonorrhea. And the CDC made a recommendation. They said, if you can't use ceftriaxone, refer the patient to an infectious diseases physician. What is the infectious diseases physician going to do? It's not as if we have the magic bullet. What they'll probably do is they'll use one of these not recommended regimens and recommend a test of cure within 2 weeks. That's the only thing you can do. And so, of course, you ask yourself, what's to be done if a patient reports an allergy to penicillin? Well, you do your best to try and disprove that. You ask them whether they've taken other types of drugs. Have you taken Augmentin, amoxicillin, Keflex, etc.? And if they say yes, you give them ceftriaxone. And so it's become much more challenging, particularly as it relates to pharyngeal gonorrhea. And think about it even beyond uncomplicated gonorrhea. Think about it in the setting of complicated gonorrhea. For example, pelvic inflammatory disease. 90% of women with pelvic inflammatory disease can be treated as outpatients. Currently in the United States, the only recommended regimen to treat pelvic inflammatory disease in the outpatient setting is a ceftriaxone-based regimen, ceftriaxone plus doxy plus metronidazole. That's the only recommended regimen because it's the only regimen that's been studied adequately. Imagine if you have a patient with PID who cannot tolerate ceftriaxone. You're stuck. You don't have a well-studied outpatient regimen. So the complications of this emerging resistance goes beyond just uncomplicated gonorrhea, far-ranging complications. And so the next question that comes up is, well, what are the drugs in the pipeline? Can we get out of this with a new drug? And unfortunately, these are the drugs in the pipeline. And these are the drugs in the pipeline, and each one of these drugs has limitations. Zoliflodacin is a topoisomerase inhibitor, and in phase 2, it was shown to have limited activity at the pharynx at lower doses. Gepotidacin is another topoisomerase inhibitor. As well, it has problematic pharyngeal efficacy, at least in the small phase 2 study that's been completed. Solithromycin had problems overall in the phase 3 with efficacy. It only had 80% efficacy for urogenital and pharyngeal gonorrhea. Delafloxacin, same thing, lower efficacy in general in the phase 3 studies. And then aztreonam, it was an open label study that only showed 33% efficacy at the pharynx. So all of the drugs that we had great optimism for in the treatment of gonorrhea, they all have their own limitations. And that's a huge problem. There are no great drugs in the pipeline to treat resistant gonorrhea. And so that's the state of gonorrhea in 2021, increasing rates, increasing antimicrobial resistance, and limited treatment options in the pipeline. It's scary, it's disturbing. And so the next question that comes up is, why have we not been able to control STIs? It should be easy enough. And so the paradigm for the modern control of STIs was introduced by Thomas Perrin back in the 1930s. It consists of finding persons that are infected, treating them, finding and treating their partners, screening those who are at high risk for this infection, and public education. And the more recent approaches have relied on the Perrin paradigm. So why have we not been able to do this? Why are we failing? It's fascinating if we look at what's happening in the world today. Screening rates, even in high-risk populations, are low. This is a study that was published recently, and it's data from the United States from 2013, 2014, but things haven't changed. And if you look at MSM, who are screened, who report condomless sex and more than 2 partners, you would think that those individuals would be screened on a quarterly basis. Only 30% were screened in the past 3 months. Only 55% were screened in the past 6 months. And only 66% were screened in the past 12 months. These are individuals who report condomless sex and more than 2 partners. We're not doing a great job with screening. Another study that just got published from Baltimore, from primary care clinics in Baltimore, showed that amongst individuals who are starting HIV PrEP, about 43% of those were not screened for STIs at the time of PrEP initiation. We're just not doing a good job with screening. Partner notification has also become more challenging. These are data from Tom Peterman at the CDC. The number of patient interviews needed to identify one untreated partner increased from 2 in the 1950s to 4 to 5 in the 1990s to 10 in 2003. And in some areas now, the number of patient interviews needed to identify a new case of syphilis has been as high as 25. It's not because our DIS officers, our disease intervention specialists, are not doing a fabulous job. It's because it's getting harder to find partners. It's getting harder because of what's happening in terms of meetings. Meeting places, physical meeting places, are no longer the primary means by which people are meeting each other. Now we've moved to the virtual setting. And so when individuals use Grindr or Scruff or Growl or whatever app that they're using to meet other people, it becomes very difficult to identify and track down these partners. And so screening rates aren't great, partner notification isn't great. And so you can see how it's become very difficult to control many of these sexually transmitted infections. Now, in addition to those things, we're also failing because of lack of resources. These are data from the United States. I presume that you're facing the same issues in Canada. When you look at the United States, the funding for CDC prevention for STIs has been flat since essentially 2003. But what that means is that, in fact, the purchasing power since 2003 has declined 40%. So in effect, there's been a 40% cut in the budget of the CDC prevention STD efforts since 2003 as rates of STIs continue to increase. Without money, you can't control sexually transmitted infections. I assume the same things are happening in Canada. And you know what? COVID-19 has only highlighted the fact that our public health system in the United States is underfunded and underprepared. And Perrin did not overtly include these in his guidance, but poverty, stigma, and structural racism are key factors responsible for the high STI rates. I can't do justice to these critical factors, as each one of them deserves its own talk. While these factors are complex, some good news is that they're finally making their way into the mainstream conversation. You can see the LA Times and the Center for Health Journalism. We're starting to talk about these factors. These factors permeate all facets of STI control efforts, from screening and diagnosis to treatment and education. If we ignore them, we're not going to be able to control STIs, whether I'm talking about the United States, whether I'm talking about Canada, whether I'm talking about anywhere in the world. Poverty, stigma, and structural racism are hugely problematic, and they permeate through everything. And so where are we in STI control in 2021? There are modern challenges. Well, there are existing and ongoing challenges. We don't do a great job screening. The modern challenge is partner notification. We've had a harder time, essentially, finding partners in the geospatial app era. There are significant complexities associated with, essentially, poverty, with access to healthcare, with stigma and structural racism. And there's a lack of political will, and that's translated by funding. There's not enough funding for us to control STIs. So these are huge problems. And these are some of the reasons, not all, but some of the important reasons why we can't control these infections. What about HIV incidence in the biomedical prevention era? What's happening? Listen, we're now in the U=U era and the PrEP era. What's going on with HIV incidence? When one looks at HIV incidence in the era of biomedical prevention, it's clear that we have yet to discover the magic bullet. In the US, the rates have been fairly flat, and the rates in Canada in 2018 was slightly higher than the previous year. Flat, but slightly higher. So while I love PrEP, I love the paradigm U=U, they're not magic bullets, it's clear. And they've been very useful, but they haven't really led to a significant decline in new cases yet. And so it's not a magic bullet. And so all of these STI and HIV data should push us to reject the chasm, this chasm that has suddenly come up between HIV prevention and STI prevention. HIV prevention is still STI prevention and vice versa. And that paradigm is absolutely essential. The very same complex challenges that we face in STI prevention are still faced in HIV prevention. There are no magic bullets. Now more than ever, we need to coordinate our approaches to ensure future successes. We also need to acknowledge that successes in one field invariably lead to opportunities in the other field. Think about PrEP. Rather than us worrying about rising STI rates because of PrEP, we should be celebrating that it's an opportunity for us to screen our patients whose behaviors put them at high risk for HIV and STIs. It's an opportunity for us to screen them more frequently, detect STIs, and treat them effectively. And so I think that approach has to be the approach that we accept and embrace. And I know many of you do that already, but some have not, and they've lost track of that approach. So what's the future of STI prevention? Well, I'm going to share some potential exciting interventions that could potentially impact rates of STIs. The first is point-of-care diagnostics or near point-of-care diagnostics. Point-of-care diagnostics, my definition, is a diagnostic that can be completed within 30 minutes. A near point-of-care diagnostic is one that usually takes a couple of hours. And point-of-care and near point-of-care diagnostics are going to be huge, and they are absolutely needed, both in resource-rich areas and resource-limited areas. As an example, this was a proof of principle study where they implemented a rapid next to point of care genotypic assay. And what they did was that assay identified Neisseria gonorrhoeae. It was a molecular assay that identified Neisseria gonorrhoeae and was also able to give clinicians immediately information about antimicrobial susceptibility to the fluoroquinolone class. And so this point of care diagnostic was used to determine whether a patient who presented with gonorrhea within 2 hours, whether they had a gonococcal strain that was sensitive to the fluoroquinolones, and whether we could use fluoroquinolones in these patients. And lo and behold, it was quite useful. What's fascinating with this, and there are several assays that are coming out for gonorrhea, for Mycoplasma genitalium, that not only detect the organism, the presence of the organisms molecularly, but they also detect the presence of antimicrobial resistance to a class of drugs. For gonorrhea, it's ciprofloxacin, and for Mycoplasma genitalia, it's macrolides. And those are very useful. Both will become useful for gonorrhea. They're not FDA cleared in the United States yet. And they will be useful for Mycoplasma genitalium, where macrolide resistance is increasing significantly. There will be also point-of-care diagnostics, usually without antimicrobial susceptibility, that will be available within 30 minutes, and their sensitivity and specificity for several of these organisms are actually quite reasonable. So point-of-care diagnostics are going to be important. What we also know is that self-collection of specimens is highly effective, and so you don't need, in fact, to come to clinic to collect your specimens for testing. And patients are quite competent at collecting their own urogenital, anal, and pharyngeal specimens and sending them in for testing. So that's also a very important progress. That's very important progress in the field because it will essentially negate the need to have to see patients in clinic to screen those patients. And we know from COVID-19, once all of those clinics shut down, how important these home testing options are. And of course, there will be in the future home-based tests. The patients can do their own tests at home. Of course, this raises interesting questions. How do you follow the epidemiology when a patient is doing their test and reacting to their test and not necessarily submitting the result of their test to the local public health department? So every intervention that's new and novel raises new and interesting challenges, but I think these are challenges that we can certainly face. So point-of-care diagnostics, novel diagnostics, home-based testing are all things that will be welcome in the field of STIs. Of course, vaccines are also very exciting. You've all heard about the New Zealand data. It was a case control study where they looked at individuals who were vaccinated with the Group B outer membrane vesicle vaccine for meningococcus, and they looked at their odds of getting diagnosed with gonorrhea And what they found was a 31% vaccine effectiveness, the meningococcal vaccine being effective against gonococcal infection. And since that study came out, there have been several other studies that have shown that biologically this is absolutely plausible. And this has reinvigorated the gonococcal vaccine studies across the world. And there are several studies now ongoing, large trials, to see whether this actually holds true with randomization. So exciting opportunities for vaccines. Now, of course, the HPV vaccine has been huge, phenomenally successful. Unfortunately, herpes vaccines, at least five vaccines to date, have not been successful. Chlamydia vaccines are on the horizon. Gonorrhea vaccines are on the horizon. Syphilis is not quite there yet, although there's a lot of work that's being done. And so vaccines are going to be important in our fight against these infections. And then HIV is not the only forum where PEP and PrEP can be useful. Of course, STIs as well. And you've all heard about the study that came out. It was a randomized trial that was nested within the IPER-gay cohort. And what they found was that post-exposure prophylaxis with doxycycline, 2 doses within 72 hours after a condomless exposure among MSM, resulted in a significant decrease in the incidence of STIs, 70% decline in the incidence of syphilis, a 70% decline in the incidence of chlamydia. So very promising. We're not yet recommending this approach. There are at least 3 large randomized controlled trials that are being done to test this again and to ensure that there are no side effects, untoward side effects, but this is certainly exciting. So while there are exciting developments in the field of STI prevention, none of these interventions are magic bullets. We have a challenging road ahead. I'm very excited about the vaccine, but I don't have any illusions that it's going to be a magic bullet. I'm very excited about point-of-care tests and home testing, but I have no illusions that it's going to be a magic bullet. It's going to take a coordinated effort. Now, this is a report published by the Institute of Medicine. It's currently in pre-publication stage at the time that I'm recording this talk. The IOM was funded by the CDC to create this report in the United States. In other words, it was funded by the US government. STI, let me just read to you the title: Sexually Transmitted Infections, Adopting a Sexual Health Paradigm. Ladies and gentlemen, the US government is talking sexual health. If that's not a cause for optimism, I don't know what is. This report reviews the complex factors that influence STIs and highlights the need for both meso and macro level interventions. The authors of this report suggest that the United States must adopt a sexual health paradigm. It must broaden ownership and accountability for responding to sexually transmitted infections. It must bolster existing systems and programs for responding to sexually transmitted infections, and it must embrace innovation and policy change to improve sexual health. What a change that is. It is the first time that the US government has spoken about sexual health. We are so far behind, but it is a cause for optimism. All right, I'm almost done. The challenges are complex, frighteningly so. Ladies and gentlemen, you know this, we all know this, there is no magic bullet. We also need to embrace this paradigm. This paradigm is alive and well. It's essential, and we have to embrace it. HIV prevention is still STI prevention, and STI prevention will always be HIV prevention. There's something that gives me hope, and it's not point-of-care tests or vaccines or new therapeutics, although I'm very excited about all of those things. I'm optimistic because of the new generation. I'm surrounded by a new generation of trainees that have embraced justice, as the driving force of change in healthcare. That unwavering belief in the principle of justice is what's going to instigate changes that will allow us to succeed at controlling these infections. I'm looking forward to effective vaccines, better tests, better drugs, but what I'm most looking forward to is watching the next generation of clinicians, researchers, and public health practitioners take over. It's critical that we encourage them and inspire them. They have a lot of work ahead of them. It's been a great honor for me and a great privilege for me to present to you today. I thank you. If you have any questions, if you disagree with me, please don't hesitate to send me an email. Thank you very much.